It's obvious after we first met a few months ago that we are on very similar pathways through medicine. And I might say a word or two about my background. You say a word or two about yours to set the scene for this. That we both were trained in traditional medicine and specialties. You in cardiology and me in endocrinology. And I would call us biomolecular doctors at that point. We believed there was a disease for every symptom and that could be defined as a medical disease. And we both quickly learned that that's simply not the truth, that there are many patients that have symptoms or diseases that cannot be defined by a medical disease, but can be defined by careful listening. So
Good.
You might, even though I know it, tell me your trip after cardiology and how you got into psychiatry and all of that.
Yeah, I came up, as you did, the academic route, but I had interesting medical school. I lived in a hospital because all the doctors and interns, residents were off to war, World War II. So I got lots of experience with two older doctors there, one from Germany, had escaped early, and the other a fellow who was from Palestine and was a Russian Jew. So those two older doctors and my roommate and I really operated the entire hospital. And so I had 3 years. We packed medicine of 4 years into 3. So it was very active. And from there I was in the United States Navy and had an internship in Boston, Chelsea Naval Hospital, and had cruiser duty, which was really a cook's tour of the Mediterranean, which opened my eyes to an awful lot of things. After that, I decided that I wanted to go where things weren't in such a hurry, which I found in Europe. People took time for lunch, 2 hours, and they talked. And over here, we're constantly busy doing something. It's a merry-go-round. So I decided to go over there and learn some more about that. So I got a job in Paris at the American Hospital of Paris. And I was able to do research there with Dr. René Lariche, the Lariche syndrome. And so I had a residency and private practice and research for nearly 2 years. And from that point on, I went back to Columbia University in the research service, and mainly in cardiology there, and came to Kansas City in 1951 after having 4 years post-grad with the Navy, as I described. So I came out to Kansas City and had a wonderful mentor, an aged fellow, Dr. Morris Ginsburg, that I'd known during medical school and in the hospital, and he asked me to practice with him. And I learned loads from Morris. He was a kind, gentle, listening doctor. He'd talk to his patients and immediately establish rapport and find out what foods the old lady liked and which natkes to fix, and I just listened and listened and listened to Morris establish rapport with new patients. And it didn't take me long to realize that the longer he talked and listened to patients, the more they would tell him about their concept of what made them sick, instead of just asking pointed questions. So I had a wonderful mentor on rapport and listening.
Right. That's a big difference in my background and yours. I kind of had to find my way there because my mentors were strictly biomolecular, biochemical, physiology, tied down academic types. So it was in the Army, when I was in the Army Medical Corps during the Cold War in the mid-50s, that I had a patient with diabetes, a young girl, very brittle diabetes, out of control, go from low blood sugar to very high blood sugar in a matter of hours. And everything I did failed to improve her condition. And I called people around the country to get telephone consultations. Nothing worked. Over a period of months, she was being admitted to the hospital every few weeks. I was getting more and more frustrated. And then the mother and the daughter disappeared from my clinic in the Army and reappeared about 4 months later, grinning from ear to ear that life is pleasant and everything worked out and all the swings and her diabetes had ceased and she was now leading a normal life. And I said, what happened? She said, well, this little girl moved in next door, and the girl I was taking care of had to take care of her as a nurse, a maid, a friend, and we gave her a little kitten. So between a kitten and this little girl she had to take care of, this obviously biochemical disease smoothed out and returned to near normal. So that stuck in my mind that something else is operating. So it was that dramatic a change for me to realize that there's a lot going on that's not just measurably biochemical or measurably a medical disease. So over the years I started accumulating more and more patient experiences, and it became clear as time moved on that many, many patients did not have a medical disease. They had symptoms. They hurt here, or they couldn't breathe here, or they had a bowel movement problem here, or they had headaches or whatever not. That probably the majority did not have a definable medical disease. And that's where you and I really come into a common pathway. It took listening to solve those issues and problems with patients. And they really had the answer if you could draw it out of them as to what was going on in their life.
I felt the same way. I learned as I practiced with old Dr. Ginsburg how to listen, but as a little time went on, I found out that there was a part of me that had not anxiety to any degree to concern me, but I always felt there was something more that I wasn't doing. And I talked to a fellow who happened to be the admitting physician from Menninger's Institute here. And he listened to me and said, that's kind of pathologic. And I thought, what do you mean? He'd ask me a question and I'd answer, and he'd say, it's pathologic. So anyhow, he said, I think analysis would help you. Well, I was in for it, and so I got into psychoanalysis. That would have been about 6-7 years after I started to practice. So I met him every Monday, Wednesday, Friday for an hour for 4 years. And I learned to be more patient with my patients and more patient with myself. And from that experience, what I learned, what I decided was that I was more interested in whole persons than their parts. And I shifted over to psychosomatic disease. And from that, as you know, I moved into psychiatric, and that was the time of confrontive psychotechnologies, beyond just psychoanalysis, Freudian. And so I availed myself of training in essentially all of the confrontive psychotherapies, and got therapized and lectured in 7, 8, 9 different approaches to learning about what made me tick.
You said earlier in our get-togethers that a statement that stuck in my mind, what the mind doesn't deal with is relegated to the body. That's a very powerful statement of what's going on. One of the reasons we're getting together here is to make this film is that medicine has moved away from listening, and I've tried to figure out why it's moved so dramatically away from listening to patients. It's the number one complaint I hear from my friends who are going to doctors. I just don't feel listened to, the doctor doesn't listen to me, and that sort of stuff, is that the technology that's currently available is so powerful, and it's, if you think about it, it's all visual. The MRI is visual, the CAT scan is visual, the arteriograms are visual, even the lab tests are visual color generators. All the scans and sonograms are visual display, and that's so compelling to the young doctors. They just order a visual test and think they're going to solve it. So the real problem that has to be listened to is ignored and put down. And there's an awful lot of over-labeling of disease going on. And I began to write about that of labeling people with diseases they don't have. So it's on those issues I hope we can help patients out there who might watch this solve some of their own problems.
Exactly.
It seems to me that from my vantage point, the thing that we really need to get into depth on is the two questions I read recently that every patient should be asked: how are things at home and how are things at work? And those trigger a look at that.
Yeah.
Your background adds a question, I think, that says what was going on in your early life that is still driving you to behave the way you do. And I hope in the next segment we can get into your analysis of scripts and how you see the need to explore the life script of a patient.
Good, good. And we did see patients exactly the same, because to diagnose a personality, you need words, tones, gestures, postures, facial expressions, and especially do you need to be present with the patient and let them talk to you rather than asking pointed questions and getting quick answers that would fit in a medical textbook.
Right. I had one mentor that meant a great deal to me, Joe Sapira, who had me tape record my interviews with patients. And then he would listen to me tape record. And what he found out was I was interrupting the patient. I wasn't giving them time. So he put a stopwatch on me and made me lag at least 6 seconds after I would ask a question.
Yeah.
And in that interval, the patient would express what really was going on.
And unfortunately, in today's world, you've got, even as I go and see a physician for whatever, he gives me 10 or 12 minutes, and he's looking at his watch.
Yeah.
And there's no time for listening.
Right. So I would say as we present this to our audience, that there are things they can do, the lay people can do, lay patients can do, to uncover what's going on in their lives. That there's somebody or some substance or something that's coming in contact with them they should look at more carefully.
Good, good. I'd go along with that.